Hi guys, welcome back to week 3. Very exciting. We are now in module 3. This week we are doing renal review. This is going to be part 1. Next week we'll continue more information about the renal system, but for this week we're doing part 1. Before we get started, there are a few things I just wanted to review. First of all, module 1, I just wanted to let you know I added an additional resource into the lower part of the announcements where I added in all the resources for your certification exams. At the very bottom, I added in a free farm course that's specifically for when you go to get your DEA that's offered out of Buffalo, New York. It's a great resource, so definitely take advantage of it. Module 2, just to review, we went over the U.S. healthcare environment, we reviewed the third-party payer roles, we reviewed the basics of the Affordable Care Act. We talked about the essentials of business practice, current reimbursement rules, and CPT coding. I'm really hopeful you guys went ahead and watched those YouTube videos I uploaded with the Real World NP, who went over a really great study guide that she created to really break down CPT coding guidelines. So please, if you felt like you didn't really understand it or you were struggling on the quiz, which was actually quite easy, to be quite honest with you. It was pretty basic. So hopefully if you guys found that you were struggling or it took too much time, you need to go ahead and review that, because again, I can't stress enough, you will be utilizing this type of coding every single day once you start practicing. So you need to understand it and you need to be able to do it quickly, right off the top of your head, basic stuff. And I'll go over the teaching tool in just a second. Again, we also went over tips for measuring and communicating value in terms of becoming a nurse practitioner, and of course, information for managing a healthcare practice and what it entails to create a business. Just so you all are aware, I did get a couple of emails that the quiz ended before you were able to finish. The quiz time actually was increased from 10 to 15 minutes because we did add respondents, and we understand that creates a little bit of a diversion. But please note that the average graduate level question test time is 1 minute per question. And yes, your boards are timed. Depending on which board you take, whether it's with the ANC or ANCC, I'm sorry, or the other one, it does range between 3 and 4 hours. They both have different guidelines because they have different types of questions. Okay, so just again, the review of module 1. I'm sorry, I didn't realize part of the video got cut off. I did get your emails. Thank you for letting me know. I will review right now. Actually, the end part that got cut off was mostly about the evidence-based practice review, and that's from chapter 5. Please just review your PowerPoint. The main points that I really just wanted to reiterate, because keep in mind, talking about evidence-based practice and looking at the hierarchy of evidence, this is a review from your research class. Hopefully you guys all took that already, but in terms of something I really want you to focus on are the key steps in implementing evidence-based practice. So if you'll look at your book at page 59, there's a box in there, box 5.1, and it just talks about your key steps. And it's very, very basic, but it's so important because anytime you're looking at any type of clinical information or looking up any information you need to know for your standards of practice or just in terms of diagnostics, you need to make sure you're getting it from an evidence-based source. So what are the questions you're asking in terms of looking at evidence-based sources? You're looking at the burning clinical question. What is this source trying to answer, right? You're collecting the most relevant and best evidence from a review of the literature, including published literature reviews, meta-analysis, and clinical practice guidelines. Remember, please look at the PowerPoint for the hierarchy of evidence. That's very important because if you break that down, it keeps it basic in terms of letting you know, okay, the level of evidence I'm reading right now, it's okay, it's medium, or it's really, really good. And that's how you look at that hierarchy. So then you're able to critically evaluate the evidence, but you also know you don't have to work that hard because it's already been critically evaluated if it is at those higher levels, okay? You want to integrate the best evidence with your personal clinical expertise, and you want to make patient reference look at patient preferences and values when you decide to make a practice decision or a change. And that's really what, all evidence-based research does. It looks at these particular criteria as it decides, what it's looking to attain in terms of evidence. And then, of course, you want to evaluate the change in your outcomes and disseminate the findings. Okay, so those were the basic things that I had talked about near the end, the one that got cut off. Again, in terms of reviewing the hierarchy, just make sure you understand your higher levels of evidence versus your low levels of evidence. And remember, the highest levels are level 1, okay? And that's your systematic reviews and your meta-analysis, or your RCTs. Okay, those are the most important things. You also want to look at page 69 for your box on the framework for evaluating health literature. And that it basically looks at the same kinds of questions, but it focuses more on when you are reading articles, research articles, how it is you're looking at them to decide if they're actually good quality studies. All right, and that's pretty much it for that. The other things we talked about were ethical principles, the definition of health. We reviewed the steps to professional licensure. Again, these websites are uploaded into module 1, so you have access to all of them. Please do yourself a favor, save them in a file on your desktop so that you have access to them when it is time for you to use them, because again, you will be utilizing all of these sites. I did add one more thing that's in there now. It's a free opioid prescriber training program out of Buffalo, New York. So go ahead and check that out in module 1. I just wanted to review a couple of other things that I'm not sure I really mentioned, but I wanted to just point out. Keep in mind the costs of all of these things that you're going to be doing, your certification exam, your state licensure, your NPI number. Actually, that's the only thing on here that's free. Your NPI number is free, but everything else costs money. Okay, so in terms of your certification exams, remember we talked about you can take it through either the ANCC, American Nurses Credentialing Center, or you have the option of using AANPCB. This is a personal decision. Me and my colleagues, most of us took the ANCC, but it's totally up to you. There are differences. You're going to want to do some research. The one thing I wanted to point out is if you are a member of the American Nurses Association, the ANA, you automatically get a discount for taking your ANCC exam, because the ANA, American Nurses Association, is the body of the that dictates the ANCC. So I became, myself and my colleagues, when we were in grad school, we all decided to become ANA members in order to get that discount on the ANCC. Now, keep in mind, every time you go to apply for certain things, or you apply for another program, in terms of like if you decided to go on for your doctorate, or if you're applying to certain jobs, when you apply for your licensure, you will need to request through the governing body that you took your exam, whether it's the ANCC or the AANP, a copy of your certification be mailed directly from their governing body to the boards, the state boards of where you're going to take your or apply for your licensure, excuse me. So for instance, because I'm an ANA member, anytime I needed to get a copy of that certification, I went onto the ANA website. They do charge you a fee every time you need that certification mailed directly somewhere. But because I'm an ANA member, they gave me a discount. But I think it's normally like $40. It's expensive. Like, you don't understand. I had to apply for 3 different licenses. That's $40 a pop. It adds up. So these are just things to consider. You may want to be AANP does not offer a discount apparently. So these are all things to just consider. You could become an ANA member now. I mean, some of you may already be ANA members. So already you're going to have a discount to take the ANCC, just so you know. Some other things to consider also are to go ahead and get your practice books. These are great books to have just for review in terms of cliff notes for certain subject matters that you're kind of struggling on, or you want to review extra. These books are great tools. So if you wanted to go ahead and get them now, that's not a bad thing. All right, they're, I think about, they range between 30 and 50 bucks. But they have a lot of great practice questions. And you do have the option actually also, once you graduate, both Leek, this is Maria Leek's book, she does the Leek review, and this is Fitzgerald's book. These are the 2 most popular, but both Miss Fitzgerald and Miss Leek both have intensive reviews before you take your exam, for the exam. So I actually took the Leek review. I loved it. I took it all online. I think the whole thing was about 500 bucks, but it was excellent. It was an excellent review, and I'm so glad I took it. Actually, everybody in my graduating class took one of these 2 reviews. A lot of them took the Fitzgerald and liked it too. Okay, again, just another review from the last module, business plan. This is just going over the inclusions of the different things that you would need to have to make sure that you are aware of if you do decide to open your own private practice. And again, the reason we talk about this so much and really kind of focus on it is because keep in mind, you're becoming a nurse practitioner so you can work independently. That's the beauty of it. That is, the perk of it. So why not open your own business, especially if you can provide quality care, especially in the market we're in. It's very hard to work at the standards of what some of these facilities and these hospitals expect of us. And it's not really fair either to us as practitioners as well as to our patients. So the idea of opening your own practice and being able to regulate your things the way you want to regulate them can be very appealing to some people. Just remember, you have all these basic things that you would include on any business plan. The bigger thing that is really, really important in terms of payment for you as a nurse practitioner is to understand the coding. And that's why we got into the coding a lot. Again, here's these chart audit tools. They are in your textbook. They're on page 1339. Here's the chart audit tool specifically for new patients. Remember, the first thing when you're coding is you need to establish which set of codes you're going to use. Are you going to use the codes for the new patients, which are the ones you haven't seen in 3 years, or are you going to use the codes for the already established patients? And those are the ones that you have seen over the last 3 years, and that are just follow-ups. So once you decide which set of codes you need to use, if it's a new patient or an established patient, then you break it down into the severity of the visit itself and what's going on. So basically, we're looking at the level 1, level 2, level 3, level 4s, level 5. I just go low to high. Low to high meaning, low, not much is going on, versus high, there's so much going on. And then you break it down from there, and you look at your reason, and based on, what's going on, you need to make sure to include an adequate amount of documentation to justify why you are coding it at the level you're coding it. A couple of things besides these things you need to also consider is the amount of time you're spending with your patient. Time does take into account, even if you only have, like, let's say it's a level 2, but it's taking you an excessive amount of time for various reasons, you make sure to document those reasons, and then you boost it up to the level 3. Okay, but you need to make sure that your documentation justifies the level. And these beautiful tools that we put in the quiz and on here that are in your book, they all give you a very easily broken down reason as to how to document the appropriate elements based on the HPI, the review of system, and your organ systems. Okay, so just remember that. Again, I can't stress enough, if you want to practice this and you really want to get good at this, go onto the module and look at those teaching tools, the NP Real World. There's 2 videos from YouTube, as well as her teaching tool that she created herself that you can download and use along with the video. And her teaching tool actually has some great verbiage that you can include in your documentation. I love those kinds of tools, especially when I first started working as an NP, because sometimes, like, you get so overwhelmed, you don't even know, like, what do I write? Like, I don't even know where to begin. And using those kind of tools just gives you a really quick outline and a refresher. Oh yeah, I know what to do. It's one of those things. Okay, moving on, let's go ahead and get into module 3 in renal. Again, this is the first part. Second part will be next week. This week you were reading chapter 43, 44, 45 in your primary care book, and then you were looking at the guidelines for chronic kidney disease in adults, hematuria, interstitial cystitis, proteinuria, and urinary incontinence. Those were the main focuses of this particular module. I did upload quite a few videos. There's, I think, about 18 different videos, supplementary videos. You do not have to watch them, but believe me when I tell you, I handpicked them specifically because they were great resources. They did great explanation of things, very, very good animations and visual, just demonstrations of concepts that you have to know for when you graduate. So please use those to your advantage. I did put the time next to each one so that you can use that to your advantage, to help kind of schedule, okay, I have 15 minutes here, I can just pop out this video, or I have 8 minutes here, let me just watch this video real quick. All right. Remember, you can access those videos and all these modules on your Canvas site on your phone. If you make sure you download the Canvas app. Okay, and if you have any trouble with anything in terms of downloading stuff or speed, or you just don't have access or whatever, do not hesitate to reach out to GU Support, our tech place in Goodwin. They're very helpful. Okay, so first things first, let's just do a basic review of the urinary system. I always like to just keep a basic picture of the body system we're working on, or the organ system, just so we can make sure to remember what it is we're talking about at this point. Again, there's a couple of beautiful dynamic videos uploaded that do a nice review of the urinary system and the flow of urine. So if you wanted to check that out on the module, go ahead and do that. Keep in mind a couple of things when we're looking at this picture. The kidneys are located in the retroperitoneal area, all right? The right kidney is lower than the left kidney because of displacement by the liver. And the most important thing to remember is the basic functional units of the kidney are nephrons, which contain glomeruli. All right, so when you're reviewing the kidney, you want to make sure you're reviewing what normal findings are. Okay, make sure you're aware of what normal findings are in terms of the kidney, so that when we see abnormal findings, we know what's not right. All right. Things to know that I want you to remember is, keep in mind kidneys regulate the body's electrolytes and fluids, which affects blood pressure. Water is reabsorbed back into the body by the action of antidiuretic hormone and aldosterone. The kidneys excrete water-soluble waste products of metabolism, for example, creatinine, urea, and uric acid, into the urine. And they secrete several hormones, such as erythropoietin, which affects red blood cell production, renin and bradykinin, which affects the blood pressure, prostaglandins, which affects renal perfusion, and calcitrol, which affects bones, okay? The average daily urine output is 1,500 mLs, and of course, oliguria is defined as urinary output of less than 400. All right, and remember, important things to note, and this isn't just to review, like you need to remember this forever. And a lot of this you may already know from being an RN, but just to reiterate, patients with pre-existing kidney disease and or diabetes are at a higher risk of kidney damage from contrast media. So CTs, MRIs, angiogram, contrast media may damage the kidneys or cause nephrogenic systemic fibrosis. All right, so be very conscientious of that in any of your patients with kidney disease or kidney disorders. Imaging tests with the highest sensitivity or specificity for kidney stones is a non-contrast CT scan. The first initial imaging you would be doing is a renal ultrasound, but after that would be a CT scan. And we'll go over more different labs and diagnostics further into the PowerPoint. Okay, so the first thing we're going to kind of get into are common urinary complaints. We're going to go back and forth a little because some of this stuff overlaps with other stuff, so just bear with me. So the first thing we're talking about is dysuria, very basic, painful urination, frequency, urgency, hesitation. Those are things you kind of want to differentiate when somebody does talk about painful urination. You want to really fine tune, okay, what are we talking about in terms of pain? Does it hurt when you go? Does it hurt because you can't go? Does it hurt after you go? Does it hurt during while you go and then it stops? Like, tell me more about it, okay? How often are we going? Are we going and then finding we're only going a little bit? When we go, do we see any blood? Does the pain come and go, or is it constant? You know, these kinds of things we're asking. Dysuria is most often associated with a bladder problem and rarely with renal disease, okay? And when we have dysuria, we're gonna go ahead and run a urinalysis. Okay, hematuria, another common urinary complaint. It's basic, let's keep it basic, it's blood in the urine. But how much blood in the urine, right? So it can be visible or occult, and it can be characterized by more than 3 red blood cells per HPF. We want to differentiate, is it transient versus persistent hematuria? Okay, does it come and go, or is it just constant? Like every time they pee, they're seeing blood in their urine, okay? There are, remember, there are 2 types of hematuria, microscopic or gross, like I said before. They can, the blood may come from the urethra, from the bladder, or from the prostate. Now keep in mind, if it's from the urethra, we're considering urethritis. If it's from the bladder, we're considering cystitis or bladder cancer. And if it's from the prostate, we're considering it prostatitis. Or if it's from the kidneys, we're concerned about pyelonephritis. So when we see blood in the urine, we are concerned, right? Blood is not normal, okay? Not in the urine anyway. So there's a couple of different things you need to consider when you do have hematuria come up as a differential, okay? We want to consider females with a history of vigorous sexual activity or exercise. These are females we need to instruct to stop exercise, and then we're going to do another urinalysis in 4 to 6 weeks. Okay, and if we're concerned about infection, like for instance, urethritis, cystitis, or pyelonephritis, the UA will also show white blood cells, okay? So then we want to order a urinalysis with urine for CNS, okay, a culture and sensitivity. If we consistently see persistent, unexplained microscopic hematuria that does not resolve, we're definitely referring to a nephrologist. Now, if we suspect gross or visible hematuria, so remember, when they say gross hematuria, that means you can actually see it in the urine. There's like a lot of blood in the urine, and it's very visible. So that would be if the urine is like pink or red or brown or blood clots are present. The next step would obviously be to look for the source of blood. If the dipstick is heme positive, then the next step is to order a microscopic urinalysis. If we suspect infection, then we're going back to our culture and sensitivity. Okay, new onset of dark reddish brown urine, edema, protein in the urine, fatigue, and decreased urine output after a recent strep throat or impetigo infection raises the possibility of glomerulonephritis, which is like an immune reaction from the infection. So that's just a rare complication that can come up sometimes, so just keep that in mind. The other thing you may want to consider if we're seeing blood in the urine and it's not due to an obvious cause of bleeding that you can pinpoint, it may be because of some of the medications they're taking. Keep in mind, red urine can be caused by rifampin or phenytoin, or ingestion of certain foods like beets, rhubarb, senna, and food dyes. So those are things to consider too. Okay, so here's just a review of the different common urinary complaints and causes. So again, we have dysuria, and different considerations or differential diagnoses you want to think about with dysuria could include bladder calculus, cervicitis, cystitis, prostatitis, urethral obstruction, urolithiasis, vaginitis. In terms of different differentials for hematuria, we're looking at possible overexercise. A lot of bicyclists sometimes will get a little cystitis and hematuria. So keep that in mind if they're exercising a lot or riding a bicycle a lot where there's a lot of rubbing and friction near the urethra, we could just get some hematuria like that. A lot of male athletes or gym rats tend to get that. Okay, you always want to consider cancer in your differentials, especially when it concerns hematuria. Neoplasia could be from the kidney, the bladder, the prostate, or the urethra. You want to consider a renal infarction like vascular disease or sickle cell. And then of course, trauma. We will get a little bit into urinary retention, but we'll get more into that later on in the PowerPoint. Okay, so another common urinary complaint is proteinuria. Now, again, this is a very broad term, just like the hematuria. It could mean numerous things, so you have to really understand what it is. It's usually indicative of a renal pathology, most often of the glomerular origin. It can be functional from acute illness, emotional stress, excessive exercise, or it could be a benign process. In terms of testing, we want to look at a full chemistry panel, fasting blood sugar, lipid profile, urine culture and sensitivity, and a CBC with differential. Obviously, the management depends on the underlying cause. Now, keep in mind, proteinuria is defined as the excretion of greater than 150 milligrams per day of protein. Patients with persistent hematuria should be evaluated to find the cause. The gold standard test for measuring protein excretion of the kidneys is the 24-hour urine for protein. And there are 4 types of proteinuria. There's glomerular, tubular, overflow, and post-renal. So serious causes of proteinuria, which remember is a sign of damaged kidneys, includes diabetic nephropathy, hypertensive nephropathy, polycystic kidney disease, and sarcoidosis. All right. So here are your symptoms of proteinuria: pain during urination, foamy urine, shortness of breath, swollen face, backache, and fatigue. And this is really what you worry about in in your patients with chronic kidney disease. Okay, so some urinary tract disorders to consider are obviously urinary incontinence, which is the involuntary loss of urine from the bladder, which is extremely frequent in women and common in older men. And there are two types. There's transient versus persistent. Again, transient being the urinary incontinence comes and goes, or it may just depend on certain activities or certain times of the day, versus persistent where it's just constant. There's no rhyme or reason. They have to where it depends, and they're just constantly going. And then, of course, we have our lower urinary tract infections, where the urinary tract is invaded by a pathogenic bacteria. We want to look at the two different types of urinary tract infections: acute versus chronic versus complicated UTIs. And we'll get into that some more. And then we have our lower UTIs, and then we have our upper UTIs. When we get into our upper UTIs, we're talking about pyelonephritis, where the infection has now entered the kidney. This is not good. We're trying to avoid getting to our upper by treating our lower and preventing the lower from getting worse and traveling upward, leading to the pyelonephritis. Okay, so remember that, like, we want lower versus upper. Upper tends to be much more severe, and it requires more treatment. A lot of the times with pyelonephritis, you end up having to hospitalize these patients, okay? It can go from bad to very bad very quickly. With pyelonephritis, of course, we're always worried about sepsis. The management does include aggressive oral therapy. Okay, so I just wanna, I wanna get back, we're gonna just talk a little bit again about incontinence, because there's a few things I wanted to really make sure we talk about. The book gets into it a little bit, but I just felt it was so important in terms of education with your patients that I wanted to just get into it. So obviously there's a couple of different reasons or factors that contribute to incontinence. We have changes in bladder function, changes in bowel function, and then medical conditions. So changes in bladder function, it could be just the decline in ability to contract, decreased capacity, decreased flow, reduced ability to concentrate urine. Urinary tract infections can cause a little bit of urinary incontinence. And this is not just in older people, this is in all ages, guys. So a younger female who gets UTIs can experience a little bit of urinary incontinence. Prostate problems in men, young or old, that can definitely lead to urinary incontinence. And then as a result of prostate cancer treatment, that can also lead to incontinence. So again, these are all reasons. This is such a common thing that a lot of people don't actually talk about because they're so embarrassed. And it's really important you talk to your patients about it, because there are methods to help improve it, if not eradicate it, that don't require medication, but the patient has to know what to do and to do it consistently. So those are the things we're going to get into. Again, there's some other reasons: pelvic floor dysfunction, which can cause stress incontinence, which can contribute to prolapse. Constipation can cause voiding difficulties. Mobility and mental capacity issues can also cause incontinence. MS, obviously, Parkinson's. These are all different reasons why we have incontinence. So if any of your patients have any of these issues, you may want to have the conversation with them and ask them how it's going if they're having any issues with this. Now, this is an older source. It's from 2016, but these are pretty consistent across the board still. So these are just the different types of common bladder issues. Again, symptoms that you would be looking for: urinary leakage with coughing, sneezing, or exercise. This is very common, especially in women who've had multiple babies, even one baby. Stress urinary incontinence, especially right after delivery, is very, very common. Where basically a woman will sneeze or laugh or cough and a little bit of urine just comes out. So they do end up wearing like maxi pads to help handle that. We have bladder overactivity, where we have frequency and urgency and leakage before we reach the toilet, as well as we have the obstruction or atonic bladder, where we have poor stream, frequency, nocturia, and bedwetting. And here, look at the treatment in terms of stress urinary incontinence: pelvic floor exercises, biofeedback with or without electrical stimulation. Of course, you always have the option of surgery. But again, a bladder overactivity, we have bladder retraining. We could consider medications if we needed to, but I would encourage you to get your patients to do these pelvic floor exercises and the Kegel exercises and bladder retraining before we start on medication. But the key with these exercises is they have to be consistent about it. All right. So in terms of incontinence, there's a continuum of care that comes with it, because it can really have such an effect on people. And I don't blame them. If this was an issue for me, I would really be very upset, and I'd have to really get some support for it, because it's not a way to live if you don't have to. So of course we have tricyclic antidepressants. For stress and urge incontinence, we have different classifications. Physiological, they talk about vaginal cones, and intermittent catheterization, as well as pelvic organ support devices. These are, and definitely in terms of nutrition, you want to cut back on caffeine, because that can definitely make stress incontinence or any kind of urinary incontinence worse. And you want to increase fiber. Okay, so here's just some things that I wanted to point out to you in terms of bladder training, and for women, Kegel weights. Okay, so we have Kegel exercises. A lot of people actually haven't heard of these. These are called Kegel weights, and they're actually different size little weights that the women would insert vaginally. And as they're able to hold the smallest weight in for a longer amount of time, then they can move on and go on to the higher weights. So it's basically like weights for your vagina. And they're actually very effective. A lot of women use them and find them extremely helpful. And it really, the great thing about these weights that I find with patients is it actually really helps them pinpoint how to do a Kegel exercise. A lot of the times you're talking patients through how to do it, and they're not actually able to isolate that particular muscle because they don't know where it is. So sometimes, even with men, in order to help them differentiate and isolate that muscle when it comes to Kegel exercises or even bladder retraining, I'll tell people, while they're urinating, urinate for a minute and then hold it. Just hold it, and midstream, hold it. And while they're holding it, have them focus on the muscle that's holding that urine in. And that muscle is what there should be tightening in terms of when they're doing their Kegels. Okay. And even for men, while they're peeing, they should try to stop and hold it and then pee again, because doing that a couple of times will actually strengthen the urethra, the muscles around the urethra. All right, and here is some key features of the bladder retraining program. Remember, you just have to remind them they have to go into the bathroom every 2 hours, whether they have to go or not, and just try. Sit on the toilet and try. They have to reconnect their brain with their bladder to remind themselves how to, teach them they have to remind their brain and their bladder to reconnect in terms of sensation and voiding. Okay, and here is some really descriptive instructions on how to educate people and how to do the pelvic floor muscles. They're supposed to do 3 sets of these exercises daily. And just keep in mind, even once they start doing it and they see improvement, the reality of it is they're going to have to do these pretty consistently for the rest of their lives, a couple of times a week, if not more often, just depending on how their bodies respond, because that is a muscle. And once it has been damaged, like with, a traumatic birth or frequent UTIs, or with, a lot of catheterizations, whatever it is, it needs constant muscular development in order to stay and maintain and not continue to have that urinary incontinence. So just remind your patients, like, they're going to have to pretty much consistently do this going forward to help maintain and manage this issue. Oh, and just so as a reminder, there's about a 15-minute video on the YouTube, of the YouTube resources of the supplementary videos, where I did post 2 doctors actually educating people how to do these particular pelvic floor muscle exercises effectively. So if you want to watch that, or even do them, just so you can get an idea of how they're done, so you're well versed for your own patients. Another common problem, urinary retention. Here is a diagram of the normal flow versus the enlarged prostate, which would cause a restricted flow. See how this prostate is normal, and now we have a swollen prostate that's pushing against our urethra, and it's causing the flow to become restricted. So what are we doing in terms of urinary retention? So if it's an acute episode where they just aren't going, we're going to do a straight cath for prolonged absence of void, especially if they have pain or bladder distension on exam. We want to identify and treat the reversible cause of acute urinary retention. So it could be from constipation, likely it's from a UTI, or it could be from any kind of medications they're taking that might exacerbate retention. And then we want to educate the family, of course, and the patient on reversible factors. After discharge, if we continue to have any issues, or if we feel like this is going to be something that needs to be followed up with, we're obviously going to make a referral to a urologist. We want to do some baseline renal imaging and possibly educate the patient on intermittent catheterizations if we find that they're not voiding. And then, of course, we're going to do follow-up, and we're going to consider annual renal surveillance just to make sure that the patient isn't getting any obstructive renal deterioration or frequent UTIs or nephrolithiasis. Okay, so back to urinary tract infections. And remember, right now we're just talking about the lower UTIs. I just wanted to talk about the epidemiology of this because it's so important to realize what bug is most commonly causing these UTIs so you know how to treat. Now I found this breakdown of the organisms that are causing the UTIs, and across the board, this is not the most up to date, but across the board, it's still very consistent that E. coli is your primary cause, okay? Now, keep in mind, cystitis or your urinary bladder inflammation can be uncomplicated, recurrent, or reinfection or relapse. And that's your lower UTIs. And the majority of the infections, like I said, are caused by the E. coli, which is like 75 to 95% of them. Other major causal agents are Staphylococcus and Pseudomonas, all right? UTIs in children younger than 3 and pregnant women are more likely to progress to pyelonephritis. So technically, children and pregnant women tend to be considered a complicated UTI, okay? The highest incidence of UTIs is usually in females in their reproductive age years. In older females, you want to keep in mind that symptoms can be subtle, but the onset of new incontinence, especially associated with any kind of fevers or change in their mental status, could be a sign of a urinary tract infection. UTIs in children definitely need further evaluation. About 2.5% of all children will get a UTI, and it could indicate possible sexual abuse. So you definitely want to investigate that further. So here's what we were just talking about before. So we have our lower UTI, which is technically cystitis. Then we have our upper UTI, which would be considered pyelonephritis, okay? We want to stay low. We want to stay low. Once we get up here, we're going to get in trouble. This is where we get really sick once it gets up into the kidney. All right, so risk factors of cystitis include sex, history of UTI, sexual activity, vaginal infection, diabetes, obesity, and genetic susceptibility. Our symptoms, you need to know your symptoms, and you need to be able to differentiate from a lower UTI versus an upper UTI in terms of symptoms, because that's very important. A lower UTI symptoms are less severe than an upper UTI. So that's one thing you're going to know right away. If we're starting to see nausea and vomiting and fever and chills and malaise, we're already thinking big infection, pyelonephritis. Now I got to worry about sepsis. Uh-oh, let's get it together here, right? Remember, causative organisms, UPEC. Keep in mind, UPEC is E. coli. I don't like all these initials, but that's the way it is. So just so you know, it's a uropathogenic Escherichia coli, UPEC. All that is E. coli. So just don't get confused when you see UPEC. Again, these are our most causative organisms. And just make sure you can differentiate a lower UTI, cystitis, versus an upper UTI, pyelonephritis. Okay, so things to, let's do a knowledge check. So all of the following groups are considered complicated urinary tract infections, except all of the following groups are considered complicated urinary tract infections, except. So let's go through. Is it either A, males, B, infants, C, pregnant women, or D, middle-aged women? What are we looking at again? Complicated. Remember that word, complicated. Okay. So all of the following groups are considered complicated urinary tract infections except middle-aged women. Why is it not complicated? Because it's very common for middle-aged women to get it, okay? The following groups are considered as complicated urinary tract infections and should be treated for a minimum of 5 to 7 days. The complicated ones are the males, the poorly controlled diabetics, the pregnant women, the children, the elderly, the immunocompromised, the recurrent patients or patients who've had recurrent UTIs or reinfections, and of course, any patient with an anatomic abnormality, including kidney stones, reflux, or obstruction. Again, women middle-aged are not considered a complicated UTI, but people who are your females, your males, and your immunocompromised and pregnant. Okay, big thing we needed to talk about that I wanted to make sure we really review before we get into more of the nitty-gritty is labs and diagnostics, and which labs we need to really make sure we know and are aware of in terms of testing for any kind of renal issues. All right, so the first thing we're going to go into is serum creatinine. So serum creatinine, the factors that affect serum creatinine are the gender, because males tend to have higher levels, race, African Americans tend to have more muscle mass, and muscle mass in general are all factors that affect serum creatinine. So keep in mind, when renal function decreases, the creatinine level will increase. So creatinine is the end product of creatinine metabolism, which mostly comes from muscle. So serum creatinine can be falsely decreased in people with low muscle volume, like older adults, and elevated values are seen with kidney damage or failure, the use of nephrotoxic drugs, and other factors. Next, we have creatinine clearance, which is a 24-hour urine. And this test is ordered to evaluate patients with proteinuria, albuminuria, and microalbuminuria. It is a more sensitive test than serum creatinine because it reflects the renal function within a 24-hour period, okay? Creatinine clearance is relatively constant and is not affected by fluid status, diet, or exercise. And it's doubled for every 50% reduction in the eGFR. So we'll get into that next. Ideally, before you check a creatinine clearance, we want to kind of have the patient avoid exercise immediately prior to and during the period of specimen collection. So during that 24-hour urine collection, when you're trying to get their creatinine clearance, you want to tell them to avoid any heavy exercise. Next, very important, is your estimated glomerular filtration rate. So that's your eGFR. I'm sure you've heard of this many times. This is the best test to measure kidney function, and it is used to determine our CKD stages. Now, please, please, please look at your book, page 660. That's table 45.1. That's going to be where you're differentiating the stages of chronic kidney disease, and that is influenced by the measurement of the eGFR and how it fluctuates in each stage. So make sure you look at that table and make sure you really can differentiate the different stages of chronic kidney disease. Keep in mind, stage 5, you're at less than 15 mLs per minute when it comes to the GFR. So that is considered kidney failure. And I have another slide on eGFR that we'll get to in just a minute. First, I want to get into blood urea nitrogen. Remember, this is the liver breaks down amino acids into ammonia and then converts it into urea. Blood urea nitrogen is a measure of the kidney's ability to excrete urea, which is a waste product of protein metabolism. If the kidneys are damaged or the renal blood flow is decreased, the urea level becomes elevated. BUN is not as sensitive as your eGFR, okay? A high BUN may be caused by acute kidney failure, which lowers the GFR. It could be caused by a high protein diet, hemolysis, CHF, or drugs. Remember, high BUN you'll find in CHF. Among patients with heart failure, you tend to have a lower GFR with a higher BUN, and that's associated with higher mortality, okay? Among critically ill patients in the ICU, an elevation of BUN is independently associated with mortality, all right? Low BUN can be caused by liver damage or liver disease. And if a patient has an abnormal BUN level, you want to check the eGFR. If the eGFR is normal, the renal function is probably normal. Okay, next we're looking at our urinalysis, which is a complete UA, consists of 3 components: a gross evaluation, dipstick analysis, and a microscopic exam of urine sediment, okay? We're looking at epithelial cells. Remember, large amounts of epithelial cells in a urine sample indicates that it's contaminated. So be conscious of that. A few epithelial cells are considered normal. Leukocytes. Okay, so what are leukocytes? Those are our normal white blood cells. And it's called the leukocyte esterase test when you do it with the urine dipstick strips. Presence of leukocytes in the urine is always abnormal in males. You know that you have an infection if your male patient has leukocytes in the urine. And a UA, a urinalysis, is a more sensitive test for infection in males than in females. So just keep that in mind. We also have the urine for culture and sensitivity, or a CNS. Remember, you want to have greater than 10 colony forming units per ml of one dominant bacteria. And remember, that dominant bacteria is usually E. coli. All right, that's our most consistent bacteria for UTIs. If there are multiple bacteria present, you may want to consider that the sample might be contaminated and you need another one. Okay, and then let's see what else. Okay, so back to the eGFR. Okay, just remember, what are we looking at? We're looking at the estimated glomerular filtration rate. And remember, it's the best test to measure kidney function, which is used to determine our CKD stages. So how do we figure out our eGFR? Thank goodness there is a beautiful app you can download, and you will have your own eGFR calculator, so you can get that number quickly. You can do it via mathematically. There are calculations that you can use, but I would highly suggest use the calculator. All right. Okay, moving on, some more labs that we need to know related to the renal system. So in terms of urinary tract infections and looking at a urinalysis, other things we're looking at are red blood cells. A few red blood cells is considered normal, but when we're looking at red blood cells, we're concerned about hematuria, right? We're looking at that blood in the urine, so we're going to look at the red blood cells. Microscopic hematuria refers to red blood cells that are only visible by the microscope, versus gross hematuria. Remember, I said that gross meaning there's a lot, so you can actually see it. You can see the blood in the urine. The color of gross hematuria ranges from pink, red to cola or brown. The source of the bleeding may come from the urethra, which just would be like a urethritis, versus the bladder, which would be considered cystitis, or we're always concerned about bladder cancer. All right. Remember, blood is never normal. We need to follow up and figure out where it's coming from. Or it could be from the kidneys, which could be from kidney stones, pyelonephritis, polycystic kidneys, or cancer. If you're seeing a lot of red blood cells as well, you may want to consider that the female patient may have their period. It could be vaginal discharge. It could be from hemorrhoids or some kind of rectal bleeding. All right. In terms of protein indicates kidney damage if it is persistent, and that would be considered chronic kidney disease. Okay. The next step would be to order your serum creatinine and your eGFR and send a midstream urine for microscopic exam. We want to follow up. We want to make sure this patient isn't in kidney disease or doesn't have kidney disease. And if he does, where are we at with it and how can we treat it? In terms of nitrites, a positive result is highly indicative of a UTI, because keep in mind, nitrites are due to a breakdown of the urea in urine, and it breaks down into a nitrite by bacteria. So that's just an end state of a breakdown of urea. So the positive result, obviously, if you had a lot of nitrites, would be that it's a positive UTI. Casts we have, which are shaped like cylinders because they're formed in renal tubules. So white blood cell casts may be seen with infection, specifically pyelonephritis, or inflammation, which would be interstitial nephritis. And then we have red blood cell casts, which are caused by microscopic bleeding in the glomeruli. And that's when we would suspect glomerulonephritis, which you would see also with edema, weight gain, and hypertension in terms of symptoms. And last but not least, we have pH, the pH of our urine. The range is 4.6 to 8. That's usually your reference range. And it's useful in evaluating kidney stones and infections. Citrus and low carbohydrate diets are associated with lower acidity versus high protein diets, which are associated with higher acidity. So those patients on your keto diet, we're always concerned about them becoming acidic. All right, so definitely need to make sure we review the drugs commonly prescribed for UTIs. Those that you have a beautiful table in your textbook on page 639 in table 44.2. Make sure you review your drug classifications and the commonly used drugs, as well as your contraindications and your special considerations and instructions. All right. The one thing I really wanted to make sure to point out is if clinical symptoms of UTI persist 48 to 72 hours after you have initiated antibiotics, you want to go ahead and order a urine culture insensitivity and a urinalysis to rule out pyelonephritis. We need to switch to another antibiotic drug class and treat for 7 to 10 days. All right, that's very important. Some other things I wanted to talk about are just some nephrotoxic drugs. I hope you guys are conscientious about drugs that can actually be toxic to the kidneys, and just be careful. So we have our ACE inhibitors, acyclovir, allopurinol, vanco, penicillin, cephalosporins, chemotherapeutics, any kind of contrast dyes like we mentioned before, your thiazide diuretics, loop diuretics, obviously drugs of abuse, cocaine, heroin, ketamine, and amphetamines. Lithium, very toxic to the kidneys, got to be very careful. NSAIDs, want to be very careful. That could definitely be a cause of hematuria. So if your patient is eating a lot of Advils or taking a lot of Advil or aspirin, you want to, and they're starting to get some hematuria, they got to cut back, right? Protein pump inhibitors, Cipro, and sulfonamides also can be toxic to the kidney. So you want to make sure you're aware of that in terms of just making sure when you're reviewing your patient's medications that if they do have any kidney issues, you want to get them off of those or lower the dosage, whatever you need to do, depending on the patient. In terms of urinary tract infections, for uncomplicated UTIs, or also known as acute simple cystitis in your healthy adult females, they're coming to you with their basic symptoms: the dysuria, the frequency, the nocturia. You're going to do your urinalysis, and likely a very low dose antibiotic, nitrofurantoin or macrobid. You want to do 100 milligrams BID for 5 days. Okay. Or you could do Bactrim BID times 3 days. There's options. You have to just pick and choose depending on what's going on with your patient, depending on their comorbidities, depending on their history. And of course, their kidney function definitely is something you want to consider. Okay, so I definitely wanted to make sure that you guys are aware of the type of education you give to patients who you are treating for UTIs, whether it's lower or upper. Specifically, if it's upper, for sure. You want to make sure you're reviewing the important key points to tell your patients. I wrote some here. You want to look at your textbook. They have great little tables too, 2 little tables. On page 642, they have patient education for lower urinary tract. And on page 645, they have for upper urinary tract. The most important thing is a couple of things. First of all, you want to, while you're educating your patient and you're observing your patient and you're looking at their hygiene practices, you're looking at their fingernails. Are their fingernails clean? Are their clothes clean? Are they disheveled? Like, how clean are they in terms of hygiene? What are their standard practices? Do they wash their hands? These are basic things that you do need to get into a little bit with your patients. Before you even get into the nitty-gritty of the actual UTI education, because standard basic hygiene in terms of hand washing is like number one, of course, in terms of education. So you want to talk about that. You want to instruct, of course, on the importance of finishing the course of antibiotic, make sure they take it for the full amount of time. You want to be educating them to drink lots of water, make sure they go to the bathroom when they need to, do not hold it. One of the things you want to educate patients on is a lot of the times they're busy, they're working, whatever. The minute they feel they need to go to the bathroom, they need to go. Holding it can lead to recurrent UTIs. You want to talk about underwear. What are your patients wearing in terms of underwear? Definitely cotton, something breathable. You want to, if they can get white cotton underwear, that's their best bet. Things with fragrances, or like lycra material, anything that doesn't breathe can definitely lead to more UTIs. You want to have your female patients avoiding wearing thongs at this point because they do rub and can cause more irritation and possibly transfer of E. coli into the urethra, okay? Female patients, you wanna tell them to avoid spermicides. Spermicides like KY jelly, Astroglide, any of those spermicides that people use for lubrication during sex can definitely cause an increase in UTIs. After they have sex, have the females make sure they pee If they can, take a shower, but most importantly, make sure they urinate after the sex just to clean out their urinary tract. And of course, if they can wash up, that's fantastic. We want to educate patient on signs of worsening infection, signs of, sepsis, of course. Definitely, if their fever gets worse, the symptoms don't get better after they start their medication, they need to follow up with you immediately, so that you can go ahead and change the treatment if necessary. Also, cranberry juice or cranberry supplements or something your patient may want to consider. Another video that I uploaded that I would highly encourage you to watch, it's literally like a 3-minute video, but it's a doctor of holistic medicine talking about the different foods, specifically celery, carrots, and a certain type of beans from his country that are excellent in terms of helping with urination and the urinary tract. So definitely watch that video. It's a, when we talk to our patients, we want to take things and break them down holistically as well. Nutrition and hydration are very basic, but they could be a very big key to preventing recurrent UTIs in patients. And some patients, they just don't know. They don't know how good celery is for you, or juicing celery or juicing carrots and drinking that type of juice straight is really, really good for you. So we always want to consider differentials in terms of our diagnoses. In lower UTIs, we want to consider different diagnoses if treatment is not working. We want to consider tumors, pyelonephritis, of course, vaginitis, and sexually transmitted infections or diseases. So that's another big thing. You definitely want to talk about sexual history, any history of STDs. When was the last time they were STD tested? What kind of contraception are they using? And, are they monogamous, or are they having sex with a lot of different people? These are things to consider, especially untreated sexually transmitted infections or diseases can definitely sometimes have just, associated symptoms with UTIs. Okay, so nephrolithiasis, that's the next thing we wanted to talk about. And this is a very basic kidney stones, all right? Again, I posted another video about how kidney stones are created, an animated video. I thought it was just really interesting to watch. Keep in mind, there are 4 types of stones. The majority of kidney stones are made up of calcium oxalate, about 60 to 70%. The rest are struvite, uric acid, or cysteine. And more renal calculi or nephrolithiasis or kidney stones, all the same thing, just so you know the terminology. Again, that's nephrolithiasis, same thing as renal calculi or kidney stones. But again, most of the kidney stones are made up of the calcium oxalate. And it's more common in males to get kidney stones. The location and the size of the stone determine the pain, which can range from a mild ache to severe pain. For example, stones located in the upper urethra or renal pelvis cause flank pain and tenderness, whereas stones on the lower urethra cause pain that radiates to the testicle or the labia of the vagina. And both can cause abdominal pain. So risk factors specifically for the majority of the stones that are from the calcium oxalate are the biggest risk factors are history of prior kidney stones and a positive family history, as well as a white race. Anybody who's had a history of bariatric surgery or gastric bypass tend to have a higher level of the oxalate, so they tend to get them more frequently. Anybody who has a high dietary intake of calcium, vitamin C, sodium, or protein, higher risk for that. If they have other risk factors include low fluid intake, obesity, diabetes, gout, and certain drugs that may crystallize in urine, such as acyclovir and triamterene. So they put you at higher risk. So it's a classic case of nephrolithiasis, or a classic patient case that you would see of a patient coming in with kidney stones is usually somebody in their 30s or 40s, male. He would usually come in with an acute onset of severe colicky pain, or we call it renal colic, on one side that comes in waves. So on his side, he's going to get these pains that comes in waves. Okay, when the pain is most severe, the patient most likely can't even sit still. They have to walk or pace in the exam room in order for the pain to dissipate. The pain usually builds in intensity and then lessens and disappears until the stone moves again. The pain is being caused by the stone moving. That's why it comes in waves. So just keep that in mind. Painful episodes can last from 20 to 60 minutes. And for some, the pain can be so extreme that it's associated with nausea and vomiting. The majority of these patients have a gross or microscopic hematuria. So you're going to see hematuria in a lot of them, especially as they're passing the stone. And the majority of patients will, like 50%, will pass the stone within 48 hours. They should be asked about a history of previous episodes. You want to ask them about their diet and, of course, any drugs that they might be taking that could be causing these. Okay, so let's just make sure we know how to differentiate between kidney stones and urinary tract infections. So kidney stones, of course, are the stone-like masses that form in one or both kidneys versus the UTI. That's infections affecting the urinary tract, including the bladder, the ureters, the urethra, and the kidneys. Estimated 1 in 10 people get kidney stones in their lifetime. Estimated 150 million people get a UTI every year. Kidney stones are more common in men than female versus UTIs are more common in females than males. There's 3 types of UTIs. You have your urethritis, lower, that's infection of the urethra. Then we go up a little bit. Then we have cystitis, where we have infection of the bladder. And then we go up to our upper urinary tract infections, which is the pyelonephritis, where we're now up in the infection of the kidneys. Okay. UTI occurs when bacteria gets into the urinary tract versus kidney stones form when the urine contains more crystal forming substances. Then the urine's fluid is able to dilute. Look at our risk factors for UTIs: lack of good personal hygiene, sexual activity, certain birth controls, urinary obstructions like kidney stones, advanced age, and menopause, okay, versus risk factors for kidney stones, which include dehydration, obesity, a diet high in salt, protein, and glucose, and digestive diseases. So most importantly, the one thing I wanted to make sure I pointed out to you is your symptoms. So in terms of kidney stones, your symptoms are severe back pain, stomach side pain, blood in the urine, painful urination, and fever, chills, nausea, and vomiting, versus UTIs, where we have painful urination, frequent need to urinate, but minimal amount of passing. The urine does have an odor, and it can be discolored. You also get backside pain, fever, chills, and nausea and vomiting. So with the kidney stones, we're diagnosing it more with blood tests and imaging tests and an analysis of already passed stones, versus UTIs, we're just doing urine tests. Okay, so now let's get into acute kidney injury, which is a sudden rapid deterioration of renal function resulting in an accumulation of nitrogenous waste. And it's often completely reversible, versus chronic kidney disease, which is a progressive loss of functioning of nephrons, which eventually leads to ESRD, which is end-stage renal disease. And the risk factors include analgesic abuse, cigarette smoking, vascular disease, cirrhosis, and multiple myeloma. Now, in acute kidney injury, it was previously called acute renal failure, just so we're clear. And also, just so you know, it's known as AKI. So we have an AKI or acute renal failure, same thing. It's an abrupt decline in the glomerular filtration rate. So we have a sudden decline in the GFR. So we remember, that's our lab test. So if we know acute kidney injury is caused by a sudden decline in the eGFR, oh, we make sure to go check that lab test, right? Many causes. In the majority of cases, pre-renal causes and acute tubular necrosis are the most common cause in about 75% of the cases. It usually lasts up to 7 to 21 days. Some patients recover in a few days, while some patients require dialysis for a few months. It is important to triage patients to determine who needs to be referred to the emergency room. So remember, kidney disease. When it comes to acute kidney injury, there is a staging system. It's called Improving Global Outcomes, Kidney Disease Improving Global Outcomes, KDIGO. So KDIGO has a staging system for acute kidney injury. And their guidelines define acute injury as an increase in serum creatinine by greater than 0.3 within 48 hours, an increase in serum creatinine from in 1.5 from the baseline from prior, like 7 days prior. We want a urine volume of less than 0.5 mLs for 6 hours. And so those are the guidelines, but just keep in mind that if it's pre-renal versus post-renal versus intrinsic. So if it's pre-renal, it's usually due to hypoperfusion of the kidneys.
And that's usually from like hypovolemia, decreased cardiac output, or medications that limit the GFR, like ACE inhibitors, ARBs, and NSAIDs. If it's post-renal causes that's causing the acute kidney injury, it's usually from a bladder obstruction, a urethral obstruction, or a neurogenic bladder. Versus if it's intrinsic causes, causing an acute kidney injury, it could be acute tubular necrosis, nephrotoxins, thrombosis, or glomerular disease. All right, so there's different reasons that we suddenly could go into acute kidney injury. The most important thing is we figure it out quickly and fix it. Now versus our chronic kidney disease, where we have now entered into the stages of our eGFR fluctuating to the severity that now we can be staged in chronic kidney disease. And remember to look at your stages. Hold on, let's see. Can I put it here? Oh yeah, perfect. So on page 660, you have your table 45.1. Definitely look at your stages differentiating the CKD, or chronic kidney disease. All right, so stage 1, we're looking at kidney damage with normal kidney function. Okay, but we're still greater than 90 mLs per minute. Stage 2, we have a mild loss of kidney function. Okay, mild. So we're between 60 to 89. Our eGFR is still 60 to 89. So our glomerular filtration rate is 60 to 89. When we're at level 3, 3A, I should say, we're mild to moderate loss of kidney function, where we're 59 to 45, and so on and so forth. The bottom line is you need to know where you start. Stage 1 starts at greater than 90. Okay. At stage 5, we're at less than 15, and that is end stage or kidney failure. Okay, so just make sure you're aware of those numbers, what you're looking at in terms of signs and symptoms, and how you would manage it. So once we're here in stage 1, we're definitely working to control our blood pressure and observing this patient closely. We're already getting him a consultation with a nephrologist sooner than later. Again, we're already with kidney disease, so we're still working to control the blood pressure and observing this patient. Already he has an appointment and he's seeing a nephrologist. And now 3, we're referring to a specialist. I'm already referring, because here when I refer, it takes me 2-3 months to get an appointment, just to get one appointment. That's not even the next follow-up appointment. So yeah, I'm making referrals and getting appointments just in case, because I already know I'm looking at 2 to 3 months out before the patient even gets to see anybody. Okay, now we're getting into kidney cancer. So here's our healthy kidneys versus kidneys with tumors. All right, different tumors. So renal tumors. So that would be abnormal tissue formations on or around the kidney that may cause or contribute to renal disease. Risk factors, again, obesity, exposure to asbestos, gasoline, or cigarette smoking. Bladder tumors are abnormal tissue masses that occur in the bladder wall lining, and management of the tumor depends on the size, type, and degree of invasion. Clinical pearl, major thing you should know: if you suspect a bladder cancer, your next diagnostic that you order should include a cystoscopy with a biopsy. So here's our stages of kidney cancer. We go in stage 1, 2, 3, 4. Okay, so stage 1 kidney, our tumor is 7 centimeters or smaller. Stage 2 is larger than 7. Stage 3, it's really big in here. They don't give a size after that, but these are really nice diagrams. Actually, I'm just looking at them. So if here, in terms of stage 4, it's already spread to other parts of the body. We have metastasis. And here's how we're staging. So again, another great table in your book, page 667, in terms of staging bladder cancer. We're looking at stages 0 to 4. And stage 4, we have already had the cancer has grown through the bladder wall and into the pelvic or abdominal wall, and it may have spread. So we already have metastasis. At this stage, treatment is palliative only, and the 5-year survival rate of 12 to 15%. So it's not much, it's not looking good at that stage.
So we have just some different visuals of the different types of kidney diseases. We have acute pyelonephritis, bacterial infection. So remember, this is our upper UTI that we don't want to get to because we're always worried about sepsis. We have chronic pyelonephritis, glomerulonephritis. It's usually more associated with lupus and diabetes. We have diabetic nephropathy. Nephropathy is the chronic loss of kidney function occurring in those with diabetes mellitus. So this kidney almost becomes basically ischemic and stops functioning. And then we have renovascular hypertension, and this is a result of chronic hypertension that causes constant and chronic narrowing of the arteries. So symptoms of metastatic renal cell carcinoma, it's not really that different than most of your sort of symptoms of cancer in general, but specifically the pain is usually on one side of the body, mostly on the back. Obviously there's fatigue, weight loss, swollen lymph nodes, weight loss, swelling around the left testicle. If it's male, bone pain is very common, and trouble breathing and fever. So I just put this graph in here so we could make sure to differentiate the different types of carcinomas associated with renal and the kidneys, just so you could differentiate the pathology as well as the clinical features. So these are just some facts about kidney care that came out of the UK that I thought were interesting. More women have kidney disease, yet more men start dialysis. Some of this you've already may know. Uncontrolled diabetes or high blood pressure are the biggest causes of kidney failure. So as practitioners, we need to make sure we really recognize that and keep our patients' blood pressure and diabetes under control, get them on a good, healthy weight and nutrition program. That's why this is so important. We don't want our patients to get to this point, and we have to educate them to let them know that these are the risk factors that are involved if they don't control their diabetes and their blood pressure. So a couple of danger signals I just wanted to make sure you guys just kept in the back of your head at all times, so that if in case it comes up, you know exactly what you need to do. So keep in mind, bladder cancer is more common in elderly male patients. Your typical patient you'd see is a male man in his 70s coming in with painless hematuria. In those cases, you always want to think cancer, and you want to order urinalysis, urine culture and sensitivity, and urine for cytology. In terms of acute kidney injury, or also known as acute renal failure, it's also very common in elderly male patients. Classic cases would be male patients in their 70s, also complaining of painless hematuria. And you kind of want to order similar things as the bladder cancer. A lot of these patients that come in with acute kidney failure, they usually have an onset of oliguria, edema, and weight gain just from fluid retention, and they complain of lethargy, nausea, and a loss of appetite. So they usually have a rapid decrease in their renal function and an elevated serum creatinine. So these patients, usually if the acute kidney injury is reversible as soon as you recognize the offending substance and it's stopped. Some of the most common causes of drug-induced acute kidney injury, just so you guys know, are aminoglycosides, contrast agents, like I said before, NSAIDs, ACE inhibitors, and protease inhibitors. And then in terms of rhabdomyolysis, I always like to bring this up because it's kind of got similar symptoms in terms of the dark urine. So rhabdomyolysis, keep in mind, it's just an acute onset of muscle pain, muscle weakness, and dark urine. Muscle tenderness and swelling may be seen, which rules out compartment syndrome. But with rhabdomyolysis, the damage the kidneys can result in acute kidney failure, which is a very common complication of rhabdomyolysis. So that's why I wanted to make sure we talk about it. In rhabdo, you will find that the serum creatinine kinase levels are very high, which is one of your biggest diagnostics to diagnose this. And these patients, you want to refer them to the emergency department. Okay. All right, guys, that's it for today. Please look at those videos. Again, I put the time in there. There's about 2 hours total of supplementary videos in your module that I feel like would make solidify a lot of this information. One of the videos is a laboratory video that really reviews the labs, and it's done by a pharmacist. So his interpretation of it is very, very good, and he does it with a very good visual presentation. So hopefully that helps. Next week, we will be getting into, let's see, the second part of renal. And I will break that down for you. You have chapters 49, 50, and 56, and then a few more pages in chapter 12 of your cash book. So make sure you review that, as well as your Coiler, your procedure book. You're going to look at chapters 114. And you do have a quiz next week. So just make sure you prepare for that. Give yourself enough time to try to answer each question. The quiz on your renal quiz is 10 questions. All multiple choice. There's no fill-ins. All right. And again, I can't stress enough, if you didn't do so great on the quiz with the coding, please look at those FNP video, the NP real world video, and upload her teaching tool and go ahead and practice with her on that tutorial. It's about half an hour. All right. Thanks, guys. Have a great week.